Hello everybody, Dr. Alberto Panero here. I have the privilege and honor to be having lunch with Luga, a good friend, a mentor, and a colleague. On the menu today is going to be UCL specifically and how to treat tears with orthobiologics. That's something that we have the real godfather here, the OG, that not only has written a lot of the literature, but it's how I've treated all my patients. So we're very lucky to get this information today. So
thank you very much, and you're saying that just because I'm old.
Something.
Dr. Panero has the privilege of being the only doctor in the United States, if not the world, that I allowed to inject me. So
Yes, thank you.
and he cured my rotator cuff. So
There
I'm
you
good.
go, with biologics.
That's right.
So, what I wanted to get, in today's lunch and learn here is to really get your story. We're also going to go over who's a good candidate for ulnar collateral ligament tears. Obviously, this is going to be the overhead athlete, more specifically baseball. And we're going to take you through who's a good candidate. We're going to divide between high school, the college, and the professional athlete. What type of biologics to use for these types of injuries. And then finish out with probably the rehab and kind of post-procedural stuff. So, I know the story, but they don't. Well, a lot of people do. But tell us your story on how you got into the whole UCL game.
Like Alberto, Dr. Panero, I trained as a physiatrist, a PM&R resident. I went and did to go 2 different sports medicine fellowships. The first in New York, and then I was privileged and honored to be able to go and do the K.O.L. and Job Fellowship. Now, this was in 1989-90.
Okay.
I was the first non-surgeon to ever do this surgical fellowship, and Dr. Job, rest his soul, felt that I needed to be able to do these procedures to be able to rehab them adequately. So they trained me not only as a non-surgeon, but as a surgeon. So I had that ability and the understanding of what happens in surgery, which went on and was just invaluable to me from a professional level throughout my whole career.
Sure.
And the other privilege was Dr. Job was a team physician for the Dodgers, and I was accepted immediately into that club. And as a fellow, we covered many games. When I finished, I went back to New York and was actually the first person that ever turned K.O.L. and Job down, and went back east for a year and a half, then went back out to LA. But that time I was away, the Dodgers asked me to cover them when they came into New York because they didn't want to use the home team physician. Did that, and I traveled from Montreal to New York to Philadelphia, and did that for years. And then I wound up going on the road with him when I moved back to California. So it was a blast, and I covered many games. And towards the end, I was actually the second doctor in charge behind Dr. Job. It was him and I that covered most of the games.
And did you have biologics back then? Was
No.
that even talked about?
No, it wasn't even a twinkle in anybody's eyes, I don't think.
So at that time, if you had a UCL injury, it was kind of the end of the career, or kind of how did it go back then?
Well, for professional athletes, we were doing Tommy Johns at the time, so they all got a Tommy John.
Okay.
So we tried to rehab. They put him on the IR for however weeks. That didn't work. They tried to rehab him. If they couldn't come back, which 60% of them didn't come back,
Yeah.
we would go and do a Tommy John, or he would do a Tommy John.
Sure.
But what we were seeing was a significant increase in younger athletes that had these injuries.
Got it.
As time went on, and looking at the modernization of baseball,
Sure.
these injuries got worse and worse. And parents thought their sons were going to be the next Nolan Ryan, so they got coaches, and
Yeah.
it became an epidemic, which it is now.
Sure.
But that procedure was geared basically to professional athletes. Occasionally
Yeah.
we would do a collegiate guy, but not back then. Now they're doing 12-year-olds,
Sure.
which is kind of ridiculous, but that's a whole nother issue.
Sure.
So in 2005, really, I didn't have much to do. I mean, we could rehab them, but it was a surgical case.
Mm-hmm.
Until Alan Mishra published his paper in the American Journal of Sports Medicine looking at the biologic treatment of tennis elbow.
Got it.
And that kind of sparked an interest of maybe this is feasible to do it with this ligament. We didn't know. So we did a pilot study. It worked. We were lucky. I mean, back then the literature was worse than it is now.
Yeah.
There was no consensus on anything. We didn't know what color PRP should be, how much blood we should draw, how we should spin it, what the bioformulations were. So I took an educated guess, first time in my life, probably plus my marriage to my wife. I have to say that because she's gonna hear it. But I guessed right.
Yeah.
I had no idea, and I say this all the time, and I say it when I get on the podium. It's like the only thing I knew about blood was red.
Yeah.
You know, I learned a lot in 20-something years, but
sure.
But I guessed that, and I thought in my head from what I could look at the literature that was already published, I felt if there was a high enough growth factor content, because that's all I knew that made sense to me,
Yeah.
I felt that I'd get a better response.
Sure.
You know, so we picked a leukocyte-rich bioformulation.
Okay.
We used an arteriocyte system, which I don't use anymore.
Yeah.
Because that's the only one that I could really find that
Time.
worked. And, you know, we hit a home run.
Yeah.
Because they got better. You know, so, you know, we went with that for a while. You know, early on, I know we're going to talk about rehab in a little bit, but I learned the hard way if we were too aggressive with these procedures, they didn't do well because we didn't understand the physiology and the biology of these biologic tissues or the whole healing process at that point. So I had some of the best therapists in the world rehabbing these patients, but we were too aggressive. We were too aggressive too quickly, and they didn't do as well. So finally, when we held the reins back a little bit, we kind of were able to see, okay, if we wait a little bit, then we can start moving them a little bit differently and protect them. You know, and that's how I practice now. It's, you know, I've become more conservative than I was back then.
When was the study published?
My study was
your study.
2013, the American Journal of Sports Medicine.
Okay, so that was, you know, a pretty landmark study. In that study specifically, you know, were they all professional athletes? Kind of what was the range?
No, there was some professional athletes, and most of them were non-professional athletes.
Okay.
I had a wide range of ages. I had young high school kids, some collegiate athletes, and some professional athletes.
Got it.
They weren't all pitchers, but they were volume throwers.
Got it.
And the majority of them were proximal mid-ligament tears.
Partial tears?
Partial tears.
Yeah, so we should, let's qualify that, right? I think what we're talking about treating with biologic is what type of tear.
Right, so the majority of them are going to be partial, some way.
Yeah. Now,
I've treated complete tears, and I've treated distal tears. And the thing you have to understand about why this tissue is damaged. There's a thing in baseball now, it's like all about velocity. Right. Velocity, velocity, velocity. Velocity kills elbows and shoulders.
Yeah.
And repetition in combination with that kills both. You know, so it's truly getting worse, not better, as far as these injuries occurring, because I mean, all these teams have speed coaches. I mean, it's all velocity coaches, and they're actually damaging. I mean, one of my best friends is Mike Soshin. We talk about this every time I go out to California to do work. But he complains to me all the time. It's like, why do they do this? Why do that? I mean, you're the manager, not me. You know? But you know, but it's true. So I mean, and that's never going to change. Yeah. You know, because that's what brings people to the stands, and that's what wins games. So, but these athletes become expendable now.
Sure. So we're looking at typically the smaller. I would assume the smaller the tear, the better. I think we can agree that proximal or mid tears are typically going to do better than distal tears.
Correct.
And then when you examine them, what degree of instability are you able to say, okay, this is not bad enough, I can do biologics, versus this is too unstable, I can't do biologics here?
Most of these cases, you can't perceive the instability. Okay. With your hands. So we'll do dynamic ultrasound, because I can measure the instability. Yeah. So we can look directly at the ligament. I can put a valgus stress across the ligament. That we validated. We use a kettlebell. But originally the work by Nazarian out of Philadelphia was using a TELOS device. TELOS device is thousands and thousands of dollars. Sure. Kettlebell is $15, maybe $20. Yeah. So I in LA, when I was starting to look at structuring this study, I wanted objective findings to be able to go along with the subjective findings that we had. I mean, it was great that people that did away and they felt better after we did it, but I had no way objectively of measuring, so I had to come up with something that I can measure the instability. Got it. So we compared two college baseball teams with the TELOS device and the kettlebell. And what we found, and we published this, was the only difference was the price of the device you were using. Yeah. TELOS was thousands, the kettlebell was cheaper. Sure. The same injuries you picked up.
And now, did you if there was no instability, you would go PRP. Was there a degree of instability that you said PRP is not going to work, surgery is better?
So
how did you divide that?
So when I defined instability, I did comparisons to the normal side.
Okay.
So if there was 2 millimeters or more of laxity in the ligament compared to the opposite side, that was unstable. That's what Dr. Job had taught us. That was his criteria. When he went in and opened up the elbow, if he could take a forceps, put it on the ligament, lift it off to the bone, they were unstable.
Got it.
And that's not much.
Sure.
You know, and you know, a little caveat of that is when I've seen athletes come down, and I'm sure you've seen this in your practice, they're a thrower, they have medial elbow pain, you do an MRI and it's normal.
Yeah.
Then you do a GAD enhanced MRI and it's normal.
Yeah.
And it may not necessarily be normal until you stress that elbow. And what I've found time after time, if I stress them dynamically, there's a difference side to side, and there's a difference between non-stressed and stressed. So if that's more than 2 millimeters, they're symptomatic and they're unstable, and that's when I'll do them.
Understood.
The whole thing about where the ligament gets hurt is all about blood supply and nourishment to that ligament. Proximally is a deep plexus of blood vessels that sits right where the flexor pronator tendon comes in, so that's nourished by these blood vessels.
Sure.
Distally, it's not. And the other thing that's different distally is the morphology of how it attaches on the sublime tubercle. It's a longer attachment. It's the same as in the MCL in the knee, and it's the same as the UCL in the thumb. That's a longer attachment, but biomechanically it's not as stable.
Got it.
So that'll break down. You know, so that's something that we look at too. But typically, you know, early on we were looking at these proximal, mid-proximal tears.
Okay.
Some were grade 2s, some were grade 1s that we did. Back then, the way I structured the study was I wanted to be able to do one injection at a time, and it was pass-fail. Either you got back to the same level of throwing or better, otherwise it was a failure.
Okay.
You know, so we followed these out over a year and a half, and they had to complete a baseball season before I would grade them.
Got it.
So we looked at them with subjective scores on a monthly basis, the dash score, the Cronin-Jobe thrower's subjective score. And then I did a dynamic ultrasound on a monthly basis for the whole year and a half. And what we found consistently across the board was at 6-7 weeks, they tightened the ligament down and their instability resolved.
And you could see that in the ultrasound, in the stress ultrasound. You can compare
it to what I had before.
Yeah.
So that was great to know, because then I was able to give the therapist a green light to start introducing a valgus load.
It. Yeah.
And they can do it safely.
Understood. Yeah.
Typically, I'll get a pro player or a collegiate player or even a high school player. They want them back in 6 weeks. I can tell them 100% guaranteed at 6 weeks it's not going to work.
Right. Because
they're not ready to withstand that torque and that valgus load.
Yeah.
You know, so once we learn this, so now I can send them to the therapist. You know, we'll have them start valgus training for the exercise program. And then once the therapist and I feel they're strong enough to withstand a progressive interval throwing program, that's when we'll institute that. And that's probably about another 2 weeks out, 3 weeks out, depending on how they progress and what I do.
Okay. Now, what are the tears that you turn away, right? So the patient presents to you with this type of UCL tear, and you're like, I can't help you biologically. You should have, internal brace, or you should have Tommy John. Kind of, which ones are the no-goes?
The ones I turn away now are the complete tears distally, for the most part.
Yeah.
If there's a big gap, particularly, I'll turn those away because I can't bridge the gap.
Gotcha.
Now, using a combination of therapies like bone marrow, and even we're starting to look at this matrix where you can actually put a scaffold across it. I've become a little bit more cavalier with these guys, but I follow them very closely. And I protect them, from themselves and their teams, because I'll lock them down. I don't let them move.
What about, I covered a lot of football, which gets a different type of UCL tear. It's typically more traumatic, right? The arm gets caught in a valgus position and there's a pop. The point being, do you see a difference in treating these between a traumatic tear or an overused tear?
Absolutely. I mean, I can protect a football player. Like linebackers get this all the time, or defensive linemen. They'll stick their hand out to protect somebody.
Sure.
Or to tackle somebody, and their elbow gets taken out.
Yeah.
but you can brace them very easily. You can play with the ligament torn.
Right.
But a lot of times, if I need to do something, we want to get this to heal, then I'll do that. But they're usually not complete tears.
Gotcha. But I guess there's no traumatic versus degenerative tear. Doesn't matter as much whether you'll use PRP. It's more like, okay, is it partial? Is it complete?
Correct.
And obviously position dependent, right? Like you said, I'm much more lenient on a linebacker doing PRP or bone marrow, bracing them, and they don't have to throw, right?
Right.
As opposed to an overhead athlete where it's like, okay, this is going to be more of a problem coming back.
They can't go out and pitch with a bracelet.
Correct, yeah.
But I will brace them, and that's something I didn't do in my original study. I didn't brace anybody.
Gotcha.
Now I don't trust any of them, so
so I just wanted, just to conclude this initial part. So degenerative or traumatic tears, we want to stick to smaller partial tears. Not that we won't treat the higher ones, but in general terms, that's going to be a better candidate. And you mentioned 2 millimeters or less of gapping. Is that another indicator? Okay. Yeah. So anything other than that, maybe you're pushing.
Well, I'll do a bigger laxity.
Yeah.
Because most of them come in, they're like 4 millimeters.
Okay.
The cutoff is usually 2. Some people even say 1 now.
Sure.
But if they're 1 to 2, there's laxity there. Think of it like a rubber band. You're just constantly stretching.
Sure.
Eventually it's going to break.
Yeah.
With our initial study, I only treated the lesion.
Yeah.
Now I treat the whole ligament because there's that plastic deformation for a ligament to basically elongate.
Sure.
So that renders them unstable. So if you don't treat the whole thing, you just treat the injury site, you're going to still have that laxity.
Yeah.
So, and we've had great success just tightening that down.
Sure.
And you can extrapolate this to any ligament. The knee, the elbow, the shoulder, the ankle. I've done everything. Even Liz Frank injuries in the foot.
I remember your case. Yeah. Now, what I wanted to hit on, something that I always try to have a conversation on who to do, who not to do, is the timeline, right? Because I think that's also very important. For instance, let's say, a college athlete who's going into his senior year, and if he has Tommy John, he's gonna miss the year, right? And
or longer.
Yeah, or longer, right? And he is not planning on going back to school. Maybe he's not. He just wants to try and play one last year. That I'll be a little more lenient and saying, well, we're gonna try it either way, but still give them realistic expectations. And other athletes, I just say, well, do you have 3 months for me to give you an answer, right? Because we're gonna do it based on your data. We're gonna shut you down for 6 weeks. At 6 weeks, if you're doing well, we'll start kind of a progressive return to throw program. And hopefully at 3 months, we have an answer. Does that sound right to you?
Absolutely.
Okay. And that's the question, right? With the athletes, can they handle that or not?
You can't, I tell my athletes, my coaches, the trainers, the agents, you can't cheat the biology.
There you go.
It is what it is. And I don't know if I said it today or I said it, I usually say this all the time. It's like, when you counsel patients and agents and parents, you have to tell them as a physician what they need to hear, not what they want to hear.
Yeah.
Because everybody's going to blow smoke and say, "Oh yeah, I can get you back in 6 weeks." It's a flat out lie. I can't even do that. And I've done this more than anybody.
Sure.
And you got to really be realistic, and that's with anything that we do biologic. Tendons, shoulders, rotator cuffs, ligaments in the knee, tendons in the knee, all that kind of stuff. You gotta tell, the biology is the biology.
Yeah.
And I've done it so long, like you have, I kind of have a sense of how long it takes tissue to heal.
Sure.
Whatever it is.
Yeah.
We try to optimize things now, from drawing the blood to doing the procedures, doing to different types of biologics and cell counts and everything. That all has an effect on what your outcome's going to be.
Yeah.
And that's where we're learning now. We still haven't gotten to a point where nobody has a consensus on what to do.
Sure. Now, I want to just finish out patient selection. So, high school versus college versus pro athlete, how does that, alter your choice on doing biologics versus surgery? How does that change your approach to the patient? At what stage in their career they're at?
So now, unfortunately, it's kind of all in one lump.
Okay.
Because these kids are just throwing as much as some of the pro guys that are throwing. Actually, the pro guys are throwing less than a high school kid or a college kid. Realistically,
that's crazy.
That's it. They're all playing on 15 different teams. Travel ball and club baseball has ruined kids' arms.
Yeah.
Because these coaches con these parents into, the kid's going to get into college, they're going to get drafted, whatever. That's not necessarily true. They're making money from all this stuff.
Right.
And parents are spending a lot of money, and they don't want to take time off from throwing.
Yeah.
You know, if you don't rest and recover, it's not going to get better. It doesn't matter what you do. Even a Tommy John. I mean, Tommy John is pretty much probably average around 18 months before you come back realistically, depending on what procedure you have done. You know, we have a higher and a quicker success rate, but I mean, when we did this initial study, we had them back in 15 weeks. Right? Pretty good, but still they're not really ready. It's like ACLs.
Yes.
You get an ACL back in 6 months, but they're still not psychologically ready.
Right.
And physiologically, they're probably not ready. You know, so I've come a little bit longer, but to answer your question, you know, the younger they are, and the less loads they put across their ligament, I will do them with probably platelets, a high concentration of platelets, and that's about a total deliverable platelet dose of about 9 billion cells.
Okay.
And I'll treat, like I said before, the injury site plus the whole ligament. I will also look at the pronator fascia, as is in here, and especially if it's a chronic thing that's basically matted down onto the ligament. So I'll try to hydrodissect that out and free it up. And I look at the tendon itself. I mean, if the tendon's damaged, that's a secondary restraint.
Right.
So you got to treat that as well.
Okay.
Nerve issues ulnar nerve issues are common with these, especially in a chronic state, just from the valgus opening, especially if they have a lot of laxity. I will treat that first non-surgically, steroids, gabapentin, things like that, calm that down, and then I'll do the biologic.
Got it.
So it drags out the time frame a little bit.
Yeah.
But I'm not going to do a transposition because I don't think they need it all the time.
Yeah.
And quite frankly, that was the biggest complication rate when I was a fellow, looking at the way these did. Remember a pitcher, Todd Worrell, came in when I was a fellow. His hand was like this, total contracted because they transposed his nerve. I'm like, what does this guy do? He goes, he's a pitcher for. I don't think he was with the Dodgers at the time. And then all of a sudden he's on the Dodgers a few years later and he's pitching. And I'm like, what happened to your hand? Like, I didn't think he would ever throw.
Right. Wow.
And it let up, but still, it's a long time.
Since we're talking about, you know, kind of the younger kids, what are your thoughts on the weighted balls? Because we have, you know, I like the idea of, you know, being able to increase your power or your velocity through a weighted ball, but I've also treated several UCL injuries from the weighted balls. So just wanted to get your opinion on them.
The problem with it is it will definitely increase velocity, but it also increases layback, which is basically they hyperextend, or they go into more external rotation.
Okay.
They're still tight in internal rotation, but they're going back, so that puts a strain across the medial elbow and medial shoulder. You know, so I'm not a big fan of weighted balls.
Got it. Okay.
Especially the way they're used.
Okay.
Because they're pitching with a weighted ball.
Yes.
They're throwing hard with a weighted ball.
Yeah, and they have a lot of, it's kind of like, you know, when you see the guy squatting 500 pounds, all their buddies are like watching the speed, right? It's like, come on, yeah.
I'm not even a fan of bands that guys
Interesting,
use to warm up.
Okay.
So if you think of it, a TheraBand, a Jaeger band, whatever the hell band you use, a resistant device, you might as well put a dumbbell because it's the same thing. It's an isotonic exercise.
Gotcha.
So you fatigue your arm warming up to a point where now you go to throw, you're already fatigued. So your mechanics are going to change.
Got it.
And there's so many different things with mechanics that can alter the stress across your elbow.
Yeah.
I mean, if you twist your ankle and you can't plant your foot or you can't push off correctly, that's going to change the way you deliver the ball. If you have a stiff neck and you can't pick up the target, you're going to open up prematurely and basically put stress across the elbow. Things like that. I mean, all that happens, and I've seen it in my athletes.
Sure. What about prophylactic PRP? Because I've gotten several calls where they're like, "Hey, my kid's in Little League. He's the star pitcher. Can you inject his UCL with PRP to prevent it from tearing?"
I'm laughing because I went through this scenario with the Angels. So Mike Socha, my friend, he's like, "Hey, what do you think about doing this at the end of the season on all our pitchers?"
Yeah.
I'm like, Mike, the Players Association won't let you do it.
Yeah.
God forbid I put any volume into this ligament and damage the ligament. That's on me.
You're right.
Some people do it.
Yeah. No, I know there's doing it.
Remain silent.
Yeah. No problem.
You know, but it's a risk.
It's a risk. Yeah.
I've had players and big name players come in for joint injections.
Yeah.
To tune them up because they've had degenerative labral tears in their hip.
Sure.
Same thing, glenohumeral joint,
Yeah.
rotator cuff a little bit. They're not going out and pitching right away. So, so they have the off season to work, and they've done phenomenally afterwards. But to do it prophylactically in a ligament, it's difficult because if you put, like you know as well as I do, if you put too much volume in, you damage that tissue.
Yeah, sure.
So you got to be careful.
And
even when I do these procedures, we were talking about this today in the course that Alberto and I taught. It comes down to volume and dose.
Yeah.
I'm looking for the highest dose with the least amount of volume because I don't want to damage I don't want to damage the tissue with the volume that I put.
Yeah. One last thing I want to touch on candidacy. You know, before it was an easier decision because it was either PRP or biologics or Tommy John, which obviously it's a very prolonged recovery. Now the advent of the internal brace has brought down the rehab significantly. How do you talk to someone about biologics, internal brace, Tommy John? Like, how do you kind of sweep between the three?
I have this conversation quite frequently with players that come in, even high school kids.
Okay.
You know, and I tell them the truth. I mean, I know what our data is and our 10-year data is.
Yeah.
You know, and you know, there's more and more data looking at the internal brace. Yeah. Because it acts as a strut and it protects the ligament. And you can do a primary repair now where you couldn't really do that before.
Sure.
But still, the data's not out there. But now there's a hybrid procedure that's come out where they're going to do a repair, they're going to do a Tommy John, and they're going to lay an internal brace on top of it. They're very stiff. Yeah. You know, and that's supposed to be the panacea now. But still, there's no long-term data on that.
Yeah. Yeah.
You know, so the way I look at it is, I mean, if it's a small proximal tear, or if it's something that I'm comfortable treating, or I'm going to use a combination of therapy with a little bit more advanced tear, as long as I think I can reestablish a blood supply to the ligament, I will tell them, look, this is my results biologically. I mean, I don't surgically treat these, so I mean, whatever that surgeon's telling you, but I can tell them what the literature says. Yeah. And I'm upfront and I let them choose. Yeah. Yeah. And I think the other big point, going back to timing, is, okay, let's say in 3 months you're not feeling it, right? Do you still have time to get the internal brace? Obviously, Tommy John's probably out, right? Or if you get it, you're really going to miss time. But, you know, how does that play into it? It's always a tough decision, right? Because no one has the guarantee, and there's no guarantee
in any of them, right? So
I get this question a lot. Yeah. And typically the question I get is, well, okay, you do this biologically. At 6 weeks now, when they need to throw, don't you feel bad if they can't throw? So before I even answer that question, I'll go back to the surgeon. I'll say, well, how do you feel at 12 months after you do a Tommy John and they can't throw? Because that happens. It happens quite frequently. Yeah. More frequently than not. Sure. So then I say to them, I don't let them answer that because I know I'm kind of putting them on the spot because they know I'm right. Sure. You know, so then I'll say, at 6 weeks, I can dynamically stress them. So if I see that ligament has actually healed under ultrasound, or even an MRI, but I don't quite often get an MRI, I just get an ultrasound because I dynamically could look at it. Sure. So if they're not lax anymore and that's corrected, then I'm confident that they'll go on. Okay. If I don't see that, then I have two choices to make. Either I do it again, which still is not putting them down too long, or I send them to the surgeon. Got it. Okay. But I look at that because even if I did it again, or I just boosted them again, sure. I mean, they're going to heal pretty quickly. Yeah. And then we just protect them out. Now, my understanding is that Tommy John obviously can work quite well, but it's also not where it lasts forever, right? Right. There's re-tears, right? I mean, they're going to go throw hard and it's going to hurt again. What do you think in terms when patients ask, well, if I get the PRP injection, is it only going to last a year? It's going to last 2 years? And how does it compare to how long a Tommy John would last? In my hands, not that I'm God's gift to this, we looked at our original 34 players that we did this on. And back then, again, we didn't do what we do now. Sure. I looked at them 10 years out because I was actually asked at our academy, American Academy of Pulmonology, to give a talk in the throwing, whatever the hell that's called, that subgroup that we had. Okay. Because they wanted me to answer the question, is PRP actually treatment for UCL injury or just biding time for a Tommy John? So that kind of irritated the crap out of me.
Yeah, yeah.
So I went back and got my old guys. I got all of them back to
Sure.
respond. I asked them a bunch of questions. I said, how long did you throw after we did the procedure? How long did you stay competitive in baseball?
Yeah.
And at what level? And then I asked them, did you have any recurrence of medial elbow pain or a Tommy John injury or a ligament injury? And when you retired from baseball or competitive baseball, was it because of your elbow?
Got it.
And are you continuing to play now?
Sure.
I think it was 96%, something like that,
Okay.
that they continued to play at the same level or higher.
Okay.
So they either went from high school to college to pro, or college to, they just remained
Sure.
and treated. None of them had a recurrence of medial elbow pain out of the first
There you go.
34 at
Sure.
10 years.
Sure.
One guy stopped throwing prematurely because he developed a slap tear and he prematurely retired,
Got it.
which wasn't his elbow. And then all of them, when I asked them why they retired, none of them was because of the elbow, and they all had continued to throw on a recreational basis.
Okay, so they did fine.
So they did fine.
Yeah. Yeah.
You know, we're looking at our data now, looking at a combination of platelets and bone marrow, and the results are actually very good, and that's how I typically will do all these higher level throws, college,
Okay.
or even high grade high school prospects,
Okay.
and college kids in my pros, I all do like that. You know, but we see a more robust healing process.
With that.
I've only had one guy fail that out of, I think I've had like 50 or 60 of these now
Okay.
that we've done that way. I have guys in the major leagues that their teams don't even know they've had this done.
Yeah.
But
Yeah.
but it's interesting. I had one kid that I did him as a junior in high school. He had a mid proximal injury. I think that was the kid, and he wound up pitching his senior year in high school. He went on to pitch collegiately at one of the Eastern Division I schools. He grew 10 inches and increased his fastball velocity 10 miles an hour,
Wow.
and had a complete rupture.
Wow.
But this was
crazy.
5 years out.
You're right. Right.
So asking about longevity of a Tommy John, it's about 5 years or a little bit, maybe within a year,
Sure.
back and forth.
Sure.
The interesting thing nowadays is, and this, I don't know if you saw this article in the American Journal of Sports Medicine, I think it was 2 summers ago it came out, looking at the cost effectiveness of treating a UCL injury conservatively or operatively. And what do you
Ooh.
think the answer was?
Cost effectiveness? Well, I would say the PRP is going to be way.
No.
No, Tommy
No.
John is.
Tommy John. They're looking at cost effective as far as time out of the game
Okay.
and money that you would collect.
Not just the cost of the procedure.
So
Yeah,
so
okay.
it was interesting. So talking to some of these surgeons,
Sure.
that, I mean, I respect these guys. I train with them, and
Yeah.
I know these guys. But they're saying, yeah, it's we'd rather do them early, so let them go back right away, fail, do them again, then they'll go back right away and fail again. I'm
Wow.
like, how is that good medicine?
So wait, I guess I'm losing. So they're saying that Tommy John is more cost effective
Right.
because they just
They
get
can get 'em back
quicker. Got it.
Yeah.
Interesting. That doesn't make any sense. Yeah.
No.
All
Not,
right.
not from someone that treats conservatively,
Yeah.
that's for sure.
All right, so we've established who the right patient is. Let's talk a little bit about technique. You know, if you want, I know this is Lunch with Luga. We're not going to give away the secret recipe, right? The secret sauce.
That's all right. Everybody knows it anyway. So.
But give us maybe an idea on like some pearls. Okay, how much blood you draw? You mentioned deliverable platelets. How many injections you do? How, do you do needle fenestration? Just walk us through your technique.
I will do right now the way I do it now. It's a little bit different than when I first started.
Okay.
I will draw 120 of blood
Okay.
majority of the time because I want that leeway. Because I don't know a lot of time. Well, I know before I go in there if I'm going to treat the tendon, I'm going to treat the fascia, I'm going to treat
Sure.
the ligament. The ligament only takes 2 mLs of blood
Okay.
at max.
Yeah.
But now that I treat the whole thing, to answer your question, I fenestrate the ligament.
Yeah.
I basically will do little aliquots across the whole ligament.
Okay.
Then I'll also put it in the fascia, or I'll hydrodissect the fascia out, and I'll also put it in the tendon if I need to.
Gotcha.
So I'd rather have more at a very high dosage
Sure.
than not have enough. And typically, on average, I'm putting about 9 billion platelets in total platelet dose for the treatment,
For the UCL.
for the UCL.
And what's
the whole thing, the whole package.
Okay, got it. And what's the volume of PRP or bone marrow that you deliver into the ligament?
Probably about 2 mLs.
2 mLs. Agreed. Now, bone marrow versus PRP. I know for a while we were looking at like a 2-to-1 ratio of bone marrow to PRP. Where are you at? Okay. So you'd like to draw 40 of bone marrow?
I draw 40 of bone marrow
Okay.
because we're actually doing a study now, which is pretty interesting. But I mean, when I was drawing more bone marrow, I was getting peripheral blood. I had a super physiologic PRP injection.
Yeah.
But I grew no CFUs.
Got it.
Which was interesting. I thought I was a poster child on teaching bone marrow exploration.
Yeah.
I mean, I was doing it wrong. I got back to the way Hernigge originally described it.
Yeah.
But the interesting is looking at, I mean, the only way I could measure what I thought I was getting from an MSC standpoint was looking at TNCs.
Okay.
You know, now hopefully I can look at actually CFU counts the way we're going to do this next arm of this study.
Sure.
But what we found, which was quite interesting, I was talking about this today, is I will go into the cortex, one stick. As soon as I enter the cortex, I do an aspiration, draw 10 mLs. I'll drop it down a quarter of a centimeter.
So just a smidge, yeah.
I just turn it, do another one.
Yeah.
Take it down another quarter of a centimeter, take another one, and take another quarter of a centimeter. Basically, I don't go past the centimeter.
Sure.
And what we find is the white blood cell count, which is what we're measuring really, it's very high the first one, drops a little bit, drops a little bit, drops a little bit, drops a little bit.
Okay.
The platelet count is low, goes up, goes up, goes up. Then the second arm of that is, then once I get my sample out, I draw another sample at 3 to 4 centimeters down.
Okay.
And then I clear the syringe, draw the sample the same as way I would draw the normal sample. And basically what that shows me is a very high platelet count, but not a big white cell count or TNC count. So you get into these different niches in the bone marrow where the megakaryocyte sits, so it's where you're producing blood. And what I found is if you draw slowly, you're drawing blood.
Yeah.
If you don't aggressively hemolyze that blood, you're not getting what you want.
Yeah.
It's the opposite of drawing blood for PRP. That it's like you gotta
nice
drop the lights in the room,
yeah.
nice and slow. And it's a big bore catheter. Yeah. I was shocked today when Jason said he took my advice.
the dialysis catheter.
Yeah, so that's the way I was taught to do it, and I never altered from that.
Yeah.
It's simple to use. I mean, your skill level. I mean, even with ultrasound, if you can't see it or feel it, you're looking at a hole and boom, you're in.
Sure.
Takes 3 seconds, but you don't get that damage to the cells.
Got it.
And that's worked.
So if we're using bone marrow, okay, we're drawing 40 of bone marrow, you get a few cc's of that.
Correct.
And then you basically will take your PRP and just do a 2-to-1. Right. And out of that, 2 cc's go in the ligament.
I know what the overall volume I want to inject.
Gotcha.
So now I'm playing mad scientist, kind of getting these ratios down.
Yeah.
To get the volume is the first thing, but the cell count has got to be high with that volume.
Do you fenestrate the ligament, or is it just one straight shot?
I mean, I'll go, so the ligament's like this, so I'll come in and I'll inject the length of the ligament.
Sure.
And then I'll come in along the flexor pronator.
Okay.
Fascia, and then if I need to into the tendon.
Got it.
If it's in here, if it's not in here, then I'm into that. But there's always spill. I mean, you're not going to get it all into the ligament because it doesn't hold that much.
Yeah.
And when you look at this, it appears different ways. Sometimes it's a little black ribbon.
Yeah.
Sometimes it's a little bit more robust tissue that you can see. So,
I would say in general terms, it's relatively well tolerated pain-wise.
Oh.
I think, like rotator cuff injection or intradisc. Like there's some PRP injections that are just ultra painful. Right. UCL, I would say, is in the middle.
Yeah, most.
Do you numb it at all, or
yeah. I use ropivacaine.
Okay.
I mean, when I first did my study, I would put 10 mLs of lidocaine in.
Wow.
But I didn't do it into the ligament. It was the soft tissue and the approach, and over it. But I never put it into it. I mean, rotator cuff's the same way. I'll do a suprascapular block on all of them.
Right.
But I'll still use ropivacaine. And I'll put a drop in because a drop of an anesthetic when you start to expand that tissue works really well and they're comfortable.
Yeah. Yes.
And then I heat them afterwards and that takes their pain away right away.
Gotcha.
But it's that sensation. It's like I tell people, I describe it as I'm pumping up a sausage. You're getting that pressure sensation.
Sure.
That's what hurts them.
Yeah, that's what hurts. Okay, so we've done the injection. Anything else to do about the injection? Needle-wise, do you use a 22 gauge needle?
Most of the time I use a 25.
Okay, 25, ultrasound guided. All right, so we've done the injection. you're going to put heat on them, and you said you are now bracing. Tell us
Correct.
a little bit about
So I'll use the hinged knee brace that I can control the range of motion.
elbow.
Elbow brace.
Yeah,
I'm sorry,
yeah,
not knee. I don't trust any of them, so I
Yeah.
lock them at neutral.
At neutral. Okay.
And I keep them that way for 2 weeks.
2 weeks.
I mean, I'm not concerned about them getting stiff because
Okay.
I want them to be stiff.
Got it.
Because I know they're not putting a load across the ligament.
Are you allowing them to come out and do passive range of motion, or you just stay in the brace?
I don't trust them to do that.
Got it.
Because if you give them an inch, they take 10 yards.
Sure. Understood.
You know, and I've treated too many kids, and even my pro guys,
Yeah.
and even the musicians. If I tell them one thing, they do the exact
yeah.
opposite. You know, so I lock them up, and then I will see them back. I mean, if I do bone marrow, I see them back in a week.
Yeah.
Make sure everything is okay. Then I'll see them back another week if they're local. Then I'll open up the brace by 10 degrees total range of motion, so 5 in flexion, 5 in extension, so they have some movement.
Yeah.
Because I don't want them to get stupid.
Sure.
Then the following week, I'll open up another 10 degrees.
Okay.
So now they're still not fully extended, fully flexed, but they're still, they can move a little bit.
They can move.
And they can, a little bit more tolerable, even supination, pronation, they can move a little bit in the brace.
Okay.
Then after that, I open them completely up, but I keep them in the brace.
Got it.
And then at 3 weeks, I'm going to start physical therapy, but it's more to work the shoulder and the scapula, the scapulothoracic joint.
Sure.
The scapula stabilizers,
Get the range of motion back.
Because they all have internal rotation
Yeah.
deficits, so we're working that in the brace.
Yeah. Are you allowing resisted isometrics of the flexor tendon or
I'll let
extensor
them move
tendon?
it.
Okay.
As long as they're in 90 degrees, I'll let them
Okay.
stay like that.
All right,
And that's fine. As long as it doesn't hurt, they're good.
Okay.
I'll have them squeeze.
Sure.
Because I don't want them, I don't want any other nerve issues, because a lot of
Yeah.
times if you're locked at 90 degrees, you're going to get some other nerve
Sure.
symptomatology. But I'll have them heat in the brace. I let them take it off to shower, but I read them the riot act to keep them at 90 degrees.
Yes.
Or cover it.
Okay.
So then a lot of mine come out from out of town, so I'm doing a lot of telemedicine stuff. And
Yeah.
the therapist I send these people to, I pretty much know around the country.
Sure.
And they know what I expect, so they'll be able to give me a pretty good assessment without me seeing them.
Yeah.
Or either that, if I'm concerned, I have them fly in.
Got it.
And then I'll do a dynamic ultrasound at 6 weeks, and once I see what I want to see, where they tighten down, then the brace comes off, and I allow them to start the therapist to introduce valgus load.
Got it.
And then we
Okay.
progress that. And it's feedback all the time. I mean, you have to talk to the therapist. You
Yes.
know that.
Yeah.
when you're trained.
Yeah.
So,
Yeah.
I mean, they're the ones that, you see them once in a blue moon,
Sure.
they're seeing them every other day.
Yeah.
You know, so I'm worried sometimes if the therapist is too cocky. Oh, yeah, I've seen a billion of these, and I do this,
Yeah.
I do that. I'm like, I don't care. You don't see mine.
Yeah. Just follow the.
So follow
yeah.
this. And I'm pretty anal about my protocol. I hate to say the word protocol, my exercise progressions, how I structure it.
Yeah.
Because I want certain things and milestones to be met before I allow them to progress.
Yeah.
And if they're having any pain or significant pain other than just soreness, I want to see them sooner
Sure.
than later.
Yeah, and I think that's a really good point for the audience, whether you're a doctor or a physical therapist. It's so key to communicate. I would say in Sacramento, I'm so lucky that I get to work with some phenomenal PTs. And they've actually helped me develop some of the exercise progressions. And I take feedback from them all the time. There's sometimes where, like, for instance, I used to lock out my patellar tendons, for weeks and weeks. And, they pulled me to the side and they're like, hey, we got your protocol. We'll follow it
How do you lock them out?
Well, I used to just put them
Neomobilizer?
at 0. Yeah, neomobilizer.
I got away from that because they're uncomfortable.
Correct.
You know what I do now?
What do you do?
I take a beach towel. Like during the day, I let them.
Sure.
I keep them out of everything.
Sure.
If they're gonna walk, they walk peg-legged.
Yeah.
Straight.
Yeah.
Because they're not putting a lot of load across
Right.
the tendons. At night, they're all gonna flex.
Yes.
So I take a beach towel, wrap it around from mid calf to mid thigh,
Uh-huh.
have them tape it so it doesn't unravel. It's a soft stop.
There you go.
So they can get a little bit of flexion, but they
Yeah.
can't bring it
The
down
bit,
to 90 degrees.
Sure.
I do the same thing for ulnar nerves,
Okay.
subluxation in the elbow. Same thing.
Same
See a
thing.
lot of musicians with ulnar nerves, especially
Sure.
drummers, with ulnar nerve pathology.
Yeah.
I lock them out like that. I don't put them in a cubital tunnel splint. because
Gotcha.
That hurts like hell. And
Sure.
it puts you in flexion.
Sure.
So I relax them here and they do fine.
Yeah. And again, I think that the point is you can't over communicate.
No, you got to think out of the box.
You got to think a little bit out of the box. And sometimes, a good therapist can be helpful on how to get to the spot, right? And like you said, they see them a lot more often than
Right.
we do. So I take their feedback, pretty
Absolutely.
significantly.
Absolutely.
All right, so we've gotten kind of out of the acute phase. At 6 weeks, re-ultrasound, if the ligament's tightening up, we typically start with like towel throws. Kind of what's your return to throw progression?
Typically, well, I'll do the same thing. I'll start with mimicking throwing.
Yes.
So sometimes it's just in the mirror with nothing.
Yep.
Then I'll progress to towels.
Okay.
And then we start, two arm plyos against the wall or against the pitchback trampoline. Then we'll progress to one arm protuberations where we're up like this and just body blades a lot to work the scapulothoracic joint and their arm from an endurance standpoint.
Okay.
And then once they're about 8-10 weeks out, probably, I've pushed this out a little bit longer now, but now it's about 10-11 weeks, I let them pick up a ball. And I've had the privilege when I was at the Dodgers, I spent 17 years with learning from one of the best, Sandy Koufax.
Yeah.
And I used to pick his brain every time I could.
Yeah.
And how to throw. And his motto is you should be able to throw hard. It should be easy to throw hard.
Yeah.
And he taught me stuff that's common sense from a biomechanical standpoint that he thought of.
Sure.
Even just the way you put your foot against the rubber.
Yeah.
Like most people will put their foot, they'll dig a hole and put their foot like this.
Gotcha.
He goes, if you're going to kick somebody, you're going to kick them this way or you're going to kick them this way.
Right.
So it's like, so he would put his foot, he would straddle his foot across. So he's everting his ankle.
Right.
But what you're doing as you start to load and push through acceleration, you're pushing with your leg just like you would swing a baseball bat. You're squatting, pushing through. So you're driving your trunk and your arm motion from your legs. And pitching, your velocity comes from your legs and your trunk. Your arm just comes along for the ride.
Actually, you bring up a great point. One of the biggest things I tell, especially all of them can use it, but the younger guys, it's like, hey, there's a reason you hurt this, right? And it could be just overload, you just threw too much. But a lot of times you're weak somewhere, you're not going through your legs, your mechanics are off. It's like, you're gonna take some time off here. It may be worth, if you have tape, try to get with a pitching coach, try to get with someone that can evaluate your throwing form and see where the deficiency's happening and why you got the tear in the first place.
I have every one of my throws, I don't care what the level is, even my pro guys, send me videotape of them throwing.
There you go.
I want to see from the top of the ball to their feet.
Yeah. I
want to see straight in front, and I want to see their arm side.
Gotcha.
Because I need to see how they plant their foot, where their foot is in space, where their back foot is, and how they sequence from their feet up through their pelvis, through trunk rotation, and where their arm is in space as they start to rotate through acceleration.
Gotcha.
And you'd be surprised. Just little nuances of the way you land your front foot.
Sure.
If you are like this with your front foot, let's start with the back foot first.
Yeah.
So like just from a beginning of throwing progression, I hate when guys, even if throwing a very short distance, they're basically doing this. No foot at all. No lower extremity. I mean, one, it's all arm, so you're going to hurt yourself. But you develop muscle memory to throw that way.
Gotcha.
So that's a problem.
Sure.
So I make them like it's throwing 101. I mean, I want them to take a crow hop to throw. I don't care if it's across the mound, flat ground. I want them to basically, their first leg, which is the back leg, I want them to step. But I want that back leg, instead of being like this if you would walk, I want that back leg to come 90 degrees to their target.
Okay, got it.
So that forces them to basically turn 90 degrees like this.
Yeah.
So there's no way they can throw across their body this way.
Yeah, yeah.
So they have to bring their arm back.
All the way back.
So it puts them automatically in the slot where they need to be.
Sure.
Then when they push through, when they come through acceleration, their front foot has to come straight to the target. Mm-hmm. If they're like this, they're going to throw across their body.
Gotcha.
If they're like this, they open up prematurely. It's called a pie thrower.
Yeah.
So they're here and exposed to the whole medial elbow. So I'm watching that, and I make them do that towel drill. I make them do that before they even pick up a ball in front of a mirror. Basically just take a step, get your feet right. Get your feet right, get your feet right, then bring your arm back.
Sure.
Get that right. And it's sequential, so they develop that muscle memory.
Gotcha.
And then I put a towel in their hand and do it. And then I put a ball in their hand.
Got it.
And that's how I progress it. And they look at me, even my pro guys.
Yeah.
They look at me like, what, are you out of your mind? I said, no, do it this way. They'll come back and say, yeah, it works.
Sure. No, yeah, those are really awesome points. I think we pretty much went through the progression there. Any final comments, any final thoughts? I thought that was awesome.
I mean, throwers are unique. I mean, not many people know the mechanics, you know, and it's an interesting science.
Yes, yes, it is. I think the key, you know, for anybody watching is understanding one, there is data for
Absolutely.
orthobiologics in UCLs. Not every UCL is going to be able to be treated with biologics, and I think that's where finding a skilled individual with experience that can also do stress testing and ultrasound imaging is a big deal. And also understand that in the right setting, it's probably going to work. It could also fail like anything else, right? And
you just got to be diligent and watch it, and you just follow up your patients. I mean, and not every UCL needs to be fixed either way.
There you go.
I mean, there's plenty of Major League Baseballs and some big name guys that have thrown without a UCL.
Yeah, absolutely. Well, thank you so much. I really appreciate it. What a treat to be here.
It's been a pleasure. This has been fun.
Awesome. Lunch with Luga. There you have it.
Thank you.